Good afternoon, everyone. My name is Morgan Gargiulo from the New England QIN-QIO, and I'll be moderating today's webinar. I've gone ahead and placed all phone lines on mute. So thank you for joining us again. This is the first session in the Leveraging Data Reports to Drive Quality Improvement. This one is specific to CHIA's all-payer hospital reports. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. The presentation was included in the Day of Details email that went out this morning, and you can also find the PowerPoint on our website, and I will put that link in chat in case, actually, Stephanie just did it for me. So the link is in chat if you haven't had a chance to download the slides yet. I'll provide you with details on accessing the recording at the end of this webinar. As I mentioned, the phone lines are on mute for the duration of the presentation. We will be taking questions at the end, but only through chat. So if you think of any questions during the presentation, feel free to enter them in chat, and we'll keep track of them and make sure to get them to our speakers at the end of the presentation. But make sure that you send your questions to all attendees. That way we can make sure to keep up with all the questions coming in. At this time, I'll pass it over to Zi to get us started.
Thank you, Morgan. Can you hear us?
And yes, I can. And Zi, I just passed you the ball, so you should be able to advance the slides now.
Great. Thank you. Good afternoon and welcome. My name is Zi Zhang, Director of Research here at the Center for Health Information and Analysis, or CHIA. We are pleased to host the first session of a webinar series on leveraging data reports to drive quality improvements. This webinar series is a result of our collaborative efforts of multiple organizations working together, including but not limited to Massachusetts Health and Hospital Association, Massachusetts Coalition for the Prevention of Medical Errors, New England QIN-QIO, and our chair of Center for Health Information Analysis. Today's session will focus on CHIA's all-payer hospital-specific readmission profiles, and the next session on May 4th will focus on New England QIN-QIO's Medicare fee-for-service hospital-specific reports. Before I introduce our speakers, let me say a few words about CHIA's all-payer readmission analysis. As we all know, unplanned readmissions are costly and potentially preventable. They have significant impact on patients' health and experience of care. Studies in the past have mostly focused on Medicare fee-for-service populations. As we all know, readmissions occur across all payer types. Evaluating all-payer readmission rates across all hospitals and patients will give providers and policymakers a more comprehensive and accurate picture to potentially improve quality and reduce wasteful spending. To calculate all-payer unplanned adult readmissions in Massachusetts, CHIA adapted the Yale CMS hospital-wide all-cause unplanned 30-day readmission measure. It's a long name. This is a measure number 1789 as endorsed by the National Quality Forum. It was also endorsed by the Massachusetts Statewide Quality Advisory Committee. The first public reporting of this all-payer readmission measure was in 2015. The most recent statewide report, based on state fiscal year 2015 data, was released last December, and the most recent hospital-specific profiles were made public just a couple days ago, this past Wednesday. We also published a report last August entitled Behavioral Health and Readmissions in Massachusetts Acute Care Hospitals. Based on our analysis in examining the relationship between behavioral health, comorbidity, and the readmission risk. That report was the subject of our November 2016 webinar. With that, let me introduce our presenters. Our first presenter, Dr. Nick Huntington, is our research development specialist here at CHIA. He is the lead analyst on our OPAIR readmission work and the lead author of the past 3 OPAIR readmission statewide reports and their corresponding hospital-specific readmission profiles. Today, Dr. Huntington will present the key features of CHIA's hospital-specific readmissions profile. We are fortunate to have Dr. Amy Boutwell, President and founder of Collaborative Healthcare Strategies, with us today. As many of you know, among many other accomplishments, Dr. Boutwell is a nationally recognized expert on readmissions. Her advisement has been instrumental to our analytical work on readmissions. She will lead us to explore how to interpret and utilize CHIA's hospital-specific readmission profiles to inform hospitals' readmission reduction and quality improvement efforts. Without further ado, let's start with Dr. Huntington.
All right, thank you, Zi. As Zi said, I'm going to give a brief overview of the readmission profiles, and we'll reserve most of the time for Dr. Boutwell to dive into how they can be used. All of CHIA's reports concerning readmissions, including the profiles, can be accessed at our website, and the address is there on the slide. You can also just go to chiamass.gov and navigate from there. As you mentioned, we publish an annual statewide readmission report, and here we're focusing on our series of hospital-specific readmission profiles. We publish profiles for each acute care hospital in Massachusetts, except pediatric hospitals and Dana-Farber. The audience for the profiles is mainly the hospitals and other stakeholders working to reduce readmissions. The goal is to stimulate thinking about readmissions, perhaps provide information that hospitals didn't already know, and help target readmission reduction efforts. We try to make these reports easy to use. They're brief, just 6 pages long. They're graphical. They're really all graphs. There's a couple of tables. And for each finding in the report, we try to provide some context. So the hospital's information is provided next to statewide numbers for comparison. I forgot to put it on the slide, but I wanted to mention that besides the PDF reports, we also publish an Excel data book that has all of the hospital-specific numbers in one place. So I'm going to just say a few words about the report's methodology, so you'll know something about where the numbers come from. As we mentioned, we're using the very long-named hospital-wide all-cause unplanned readmission measure. It's the same measure that's used by CMS in their hospital readmissions reduction program. There are 2 big changes we made in adapting the measure for use here in Massachusetts. We modified it to run off of our data source, which is our hospital discharge data set. And we're working with the all-payer population here, not the Medicare fee-for-service population on which the measure was developed. The measure works by defining for each hospital a set of what we call index discharges. Those are discharges that are eligible for inclusion in the measure. We then see how many of those are followed within 30 days by a readmission. It's important to keep in mind that there are certain categories of discharges that are excluded from the pool of index discharges. The 2 biggest exclusions are obstetric discharges and discharges where the primary diagnosis is psychiatric. The Yale CMS measure has built into it a risk adjustment methodology. This allows for the calculation of risk-adjusted readmission rates, or RSRRs. They permit fairer comparisons among hospitals by adjusting for patient case mix and hospital service mix. Only the first couple of data displays in our report use these risk-standardized readmission rates. Most of the data we show is not risk-standardized because we're looking at subgroups within hospitals rather than comparisons across hospitals. One final thing on the methodology. CHIA has a policy that, in order to protect patient privacy, to suppress cells with fewer than 11 cases. So in these reports, we suppress any numbers based on fewer than 11 people, 11 discharges, or 11 readmissions. So sometimes we'll suppress individual points on a graph, sometimes we'll suppress an entire graph. For small hospitals, many of the graphs can be suppressed, but hospitals can request their own report in unsuppressed format by getting in touch with us. Okay, that's enough on the methodology. Now I'm going to just walk through the report. I put a screenshot of each of the 6 pages up here in the slides, and I'll just briefly walk through what we have. Rather than calling out a particular hospital in this presentation, I've just labeled it sample hospital. So that's who we're dealing with here. This is the first page of the report. The report starts with some introductory text, and then in the lower right corner, there's a table giving some top-level readmission statistics for the hospital and statewide. This hospital, if you can read it, had just under 26,400 discharges eligible for inclusion in the measure, and of those, 4,100 resulted in a readmission, which works out to a readmission rate of 15.8%, which happens to be exactly the same as the statewide rate. There's also the risk-adjusted rate for 2015, which for this hospital is 16.6. So that's the overview page there. And then the second page has a couple more overview graphs. The graph in the upper left corner shows the spread of risk-standardized readmission rates for the 60 hospitals. Each hospital here is represented by a dot, and the readmission rate range from low over on the left to high over on the right. The dots are colored by the hospital cohort, so there's community, teaching, academic medical center, and specialty. The hospital that this report is for, in this case our sample hospital, is indicated by a red dot. You can see most of the hospitals fall in that sort of 15 to 17% range. There's one specialty hospital with a very low risk-adjusted rate, and it's the gray dot over on the left by itself. So that graph shows the risk-standardized readmission rates in comparison to other hospitals. The graph in the upper right corner of the page shows the trend for our sample hospital over time in comparison to the statewide rate. So those first two graphs show the sample hospital's rates versus other hospitals and over time. The rest of the report really zeroes in on the readmissions at sample hospital and breaks them out in various ways. The bar graph in the lower left shows for the readmissions how much time passed between the initial discharge and the subsequent readmission, both for this hospital and statewide. And the final graph on this page in the lower right shows readmission rates by age for this hospital and statewide. You can see the hospital had a slightly higher rate for younger patients than statewide, but it tracks the statewide figures pretty closely. The next page of the report focuses on two of the important breakouts that we always look at in the admissions reporting. That's the payer type of the index discharge and the setting to which the person was discharged. The top two plots are about payer type, and the bottom two are about discharge setting. The dot plot in the upper left corner shows readmission rates by payer type for our sample hospital and for the state as a whole. Readmission rate is on the vertical axis, and the white crosses show the readmission rates for each of the 3 payer types: commercial, Medicaid, and Medicare. The size of the boxes in the graph is proportional to the number of readmissions for each of those groups. So you can see the readmission rate for commercially insured patients is about 12% at this hospital, Medicaid is about 20%, and Medicare is about 18%. So that's the readmission rates by payer type in that chart. The chart in the upper right is also about payer type, but it shows some additional information. In this chart, the bar on the left shows the payer type breakout for all the eligible or index discharges at the hospital. The bar on the right shows the payer type breakout for the readmissions. You can see the readmissions skew more towards Medicare, the blue slice at the bottom of the bar. So at this hospital, 49% of the discharges are funded by Medicare, but they account for 57% of the readmissions. The bottom two graphs on this page are exactly the same format as the top two, but they're focusing on discharge setting instead of payer type. We break discharge setting into 5 categories. We've got home, HHA, which is home with home health agency care, hospice, rehab, and SNF, or skilled nursing facility. This next page covers conditions associated with readmissions. There are two ways we typically think about the impact of different conditions on readmissions. We can think about the diagnoses that have the highest rates of readmission, and then the diagnoses that have the highest numbers of readmissions. The graph on the left shows the 10 conditions associated with the highest rates of readmission at our sample hospital. The blue bars in the graph show the readmission rates at sample hospital, while the green bars underneath give a comparison of the statewide rates. So you can see there's some conditions here with very high rates at our sample hospital, ranging from alcoholic liver disease at the top at almost 41%, down to chest pain still very high at 30%. It's important to note that though those rates are high, they may not account for many absolute numbers of readmissions because they could be low-volume conditions. So the chart on the right shows the 10 diagnoses responsible for the largest numbers of readmissions at our sample hospital. The filled-in blue bars are the main thing to focus on. They show the counts of readmissions at sample hospital for these top 10 conditions. You can see they get shorter as you go down the graph from the first one down to the 10th. The blue outlines in the plot there show the volume at the hospital associated with these conditions. And then the green bars in the panel on the right show the same information but for the statewide situation. So this hospital heart failure is the condition associated with the largest numbers of readmissions. Because our data set has discharges from all Massachusetts acute care hospitals, we're able to report on situations where a patient is discharged from one hospital and readmitted to another. So this page focuses on that. So what we have here are cases where the patient was discharged from sample hospital but readmitted to a different hospital. We include these because this might be information that's harder for hospitals to obtain because it can't come directly from their own data systems. So the pie chart on the left, pie charts, on the left show the overall numbers. If you look first at the bottom pie, the statewide situation, we see that statewide about 82% of readmissions are back to the same hospital that discharged the patient, and 18% are readmitted to other hospitals. And for our sample hospital, it's a little higher. The top pie shows a proportion of just over a quarter, about 25% of their readmissions are going to other hospitals. The charts on the right give more detail about these readmissions to other hospitals. The top one shows the top 3 hospitals to which patients were readmitted. The middle one shows the regions, top 3 regions where these patients were readmitted. And the bottom one shows the types of hospitals that they were readmitted to. The last page of the report focuses on frequently hospitalized patients. So we define frequently hospitalized patients as those who had 4 or more visits within a 1-year period. The upper bar graph on the left shows the situation at sample hospital, and the one underneath it gives the statewide figures. So at our sample hospital, frequently hospitalized patients, as we define them, constitute only 7% of the patient population, but that 7% of the people accounts for 24% of the discharges and 57% of the readmissions. And those figures are very close to the corresponding statewide numbers, which are underneath. The right side of the last page here has a more detailed table that breaks out the characteristics of the frequently hospitalized patients and other patients, and break it down here by payer type. All right, so that's the end of the walkthrough on the report. I'm going to pass it now to Dr. Boutwell to take us through some of the implications for practice.
Great. Thanks so much, Dr. Huntington. And I just want to say how incredibly valuable these hospital-specific reports are and can be for quality improvement. And I want to recognize how unique these hospital-specific profiles are in the country. First of all, it's unique that CHIA is producing all-payer reports, and it is even further more unique that there are hospital-specific profiles with statewide information and hospital-specific information side by side, and so that you and your own organizations, you can use this information however you see fit. You can, you can look at other hospitals in the same region. You can look at your own hospital trending over time. You can look at your hospital and how it compares to another hospital in the Commonwealth that you consider to be leading best practice. And it's just the richness of this information, the uniqueness of the public good that CHIA is contributing to quality improvement is just very profound and special. And so it's a real privilege to be part of this research group producing this information. So I'd like to talk a little bit about how we can use this information to drive improvement. So I'd like you to consider for a moment, and pull out your pen and write this down for yourself. I'd like you to consider, what is your hospital's readmission reduction goal? Specifically, what are you trying to do? Okay, reduce readmissions. For whom? Which groups of patients is your hospital currently focused on? Are you focused on Medicare fee-for-service? Are you focused on the so-called, quote, penalty conditions, Medicare fee-for-service with the 4, 5, 6 different discharge diagnoses? Are you looking at Medicaid now that you may be entering into a Medicaid ACO? Which patient populations are you focused on? What's your goal? By how much are you aiming to reduce readmissions? And compared to what? And what is what's the time frame for your goal? So that's the components of a good readmission reduction aim statement. What, for whom, by how much, and by when. So it would be great if you made those notes as we went through some of the rest of the concepts in this webinar, and you can ask yourself, how would this information help me achieve better performance on my readmission reduction goal, whatever that goal is. Next slide. So let's think about the way that your hospital's readmission reduction goal may be evolving. This is a time of great change in the healthcare delivery system, and we have much more work to do, as we all know. So your hospital may be focused on reducing readmissions from a clinical quality improvement standpoint. You may be thinking about specific diagnoses, and you may have embraced already that readmissions should be reduced for all patients, regardless of their payer type. A second reason why your hospital may be working on reducing readmissions, of course, is to minimize the readmission penalties that your organization might be exposed to. Third would be to optimize shared savings. Many organizations in the Commonwealth are part of an ACO or an alternative quality contract of some sort, or a bundled payment arrangement. And now, of course, we have in the field the Medicaid ACO coming into play, which I know is increasing the perspective of many organizations in the Commonwealth. And finally, some hospitals may be readying themselves for full-scale delivery system transformation, where they're focused on value and population health. And that, of course, would encourage us to look at a readmission reduction goal more broadly and reconsider the types of risk groups that we might want to focus on: behavioral health, frailty, and other types of important areas of consideration. So what I'd like to encourage you to think about is, regardless of your current readmission reduction goal, focusing on all-payer readmissions and reducing all-payer readmissions really is possible. And I'd like to share with you, just as food for thought, some all-payer readmission run charts that I have been privileged to be a part of, really showing that when you focus on reducing all-payer readmissions, it can be done, and it can be done in the real imperfect world in which we're all operating. So this first run chart is from a community hospital in Maryland that many years ago decided to move to reducing all-payer readmissions. And you can see over time they focused, the green line was all-payer. And the component of their work I was helping them focus on was to renew and refresh their focus on the Medicaid population per se. And the neat thing is that although many of us in readmission reduction work have always thought about the older adults, there's a lot that can be done for the Medicaid adults as well. And so I just just want you all to know, I guess, from my experience, that it is possible to use this all-payer information. It's very helpful to focus on new risk groups that we haven't yet focused on, like the Medicaid population, and that improvement really, A, is necessary, and B, can happen. So next slide. The next slide is from a very different hospital, a safety net hospital in downtown Chicago. And similarly, because they're a safety net hospital, their focus was always on, if you will, Medicaid or all-payer, because they just had such a relatively small payer mix around Medicare. So again, they said we need to figure out what our readmission patterns are, and they didn't start with Medicare. They started with really looking at their data and looking at their root causes, and their strategy was all about social complexity and behavioral health issues. And you can see how successful this hospital's been in driving down their all-payer readmissions, which really, as you can see in this pattern in the red, is almost synonymous with their Medicaid readmissions. So those of you who are from safety net hospitals, this has a lot of relevance for your work. Next slide. So how can we get results in hospital-wide readmission reduction and achieve the goals of the Commonwealth, cost containment in the Commonwealth, and achieve your hospital's goal of delivering high-quality, patient-centered care, and ensuring that every patient who leaves your hospital has the best follow-up care that they need in order to not have to return avoidably, if at all possible. We all need in quality improvement, we all need to start somewhere. And so I do want to acknowledge that starting somewhere with a specific target population is always a good idea in quality improvement. And that's, of course, where the Medicare readmission penalty program brought us up to this point. The Medicare readmission penalty program stimulated action, it provided focus, but it created a few blinders. So as we go through this next section, think about, again, your readmission aim statements, and think about whether or not you've looked at your data from a comprehensive perspective to really identify which patient populations in your own hospital are truly at high risk of readmission above and beyond the focus areas that the readmission payment penalty program has focused us in on over the past several years. So just a few key points about the penalty program. It focused us on looking at patients in diagnosis-based categories. Of course, this is helpful, but it's not the only way of thinking about readmission risk. So you're all very well familiar with thinking about heart failure, AMI, pneumonia, COPD, et cetera, readmission risk. But as your data might show you from an all-payer standpoint, those are actually not the top 5 or 10 diagnoses that lead to the highest numbers of readmission, and certainly not leading to the highest rates of readmission. So I encourage you to look at your own chart that Dr. Huntington walked us through, looking at those less frequent but very high rates of readmission. HIV, alcoholic liver disease, those always come up. They're very, very at-risk patient populations, and why ever would we not include them in our quality improvement efforts, I would ask. The second, of course, category is many of us have been very focused on Medicare fee-for-service, an important group to be sure, the most readmissions to be sure, as our CHIA reports demonstrate. But what you can also see is that Medicaid adults are at as high, if not sometimes higher risk of readmission as a payer group. And so it's really important to recognize the risk that occurs there. And finally, if we look at population health in an all-payer, all-cause readmission profile like this, we can really start to think about other ways of defining risk of readmission. We don't always have to define risk of readmission by diagnosis. Perhaps we might look at other categories, the behavioral health comorbidity, as our other report showed last fall, social complexity, personal history of frequent utilization, functional status, frailty, etc. These are other robust ways of thinking about patients who are at risk of readmission without being limited to specific diagnoses. So what I have been fortunate to do over the past 5 years is lead a national research effort with my colleagues at JSI here in Boston for the Agency for Healthcare Research and Quality, really looking at how to expand and adapt those quality improvement principles that we all know of very well that had their genesis in the geriatric health services research literature, and ask the question, how can we adapt these strategies to better serve the Medicaid population? And you know what? In doing so, we really learned that it's not just about how to adapt to the Medicaid population, but how to adapt to an all-payer environment, which I think is very timely for us here in the Commonwealth of Massachusetts. So what we learned is that hospitals who have hospital-wide readmission reduction universally have the following 3 features and increasingly have the 4th as well. So all hospitals who have successfully reduced their readmissions hospital-wide, they know their data. They analyze, track, trend, display, slice, dice, share, post. Data is not secret. It is not threatening. It is a tool. And I really encourage you to use this report and the subsequent report you learn of from HCA to reinvigorate your commitment to using data to drive improvement. It is a feature of successful organizations. Number 2 is they take a broad concept of readmission risk. Years ago, they moved well beyond case finding for specific diagnoses, and they started looking at patients at risk of readmission through these broader categories, such as unmet social needs, behavioral health comorbidities, a history of frequent utilization, frailty, cognitive impairment, etc. Not limited to whether or not the patient is here for a heart failure exacerbation per se. Number 3 is that every successful hospital that I've ever met has a multifaceted strategy that involves, at minimum, improving hospital-based processes, actively collaborating and engaging in shared process improvement and work across settings, and delivering enhanced services for patients at very high risk of readmission once they leave the hospital for that 30-day period to support them in accessing the care and achieving stability so that they don't need to return, again, unnecessarily. Increasingly, at these, on the HCA side, could you mute yourself, please? Thanks. Increasingly, we see that successful hospitals are using technology to make this multifaceted population health work better, quicker, more reliable, using automation, etc. And these are really important modernized tools for population health work. Next slide. So for those of you who have not yet become familiar with the Agency for Healthcare Research and Quality's publication that was the outcome of this work on Medicaid readmissions, I would commend it to you. It's called Designing and Delivering Whole Person Transitional Care, and we call it the Aspire Guide. The link is there, and the guide is, of course, a narrative quality improvement guidebook, and it comes with 13 downloadable tools. I'll also mention it comes with a 6-part webinar series attached to it as well. Next slide. The main driver diagram, the way that we analyzed how hospitals achieve hospital-wide readmission reduction was through a 2-part strategy. And you'll notice that this is a divergence from many of the other quality and improvement toolkits that you probably have seen on reducing readmission. Many of the toolkits move straight into action. What should we do? What are the actions we should take? And our observation is that the actions need to be grounded in a data-informed and root cause analysis basis. And so where teams have had success, it's because they know exactly who they're targeting. They have customized solutions to address the root causes of readmissions in the disparate patient populations that they are focused on. And thus, the actions that they take are much more successful. And so again, I just wanted to bring to your attention the way that the advisement and the driver diagram here for the Aspire toolkit is really an augmentation of things that you may have already been exposed to in the admission content writ large. Moving here into data. This is really where our work has very well aligned with what CHIA now brings to you. In the Aspire toolkit, we recommend that hospital quality improvement teams run this 15-point analytic plan for yourself. And now, it happens to be that this 15-point analytic plan is practical, it's feasible, your hospital-based analysts can do this, it's been well vetted in the field. However, it's a lot of work. It's a lot of work. Next slide. And we've created a tool, an Excel tool for your analysts or for analysts in the field to run these analyses, populate an Excel spreadsheet, and develop visuals to facilitate your quality improvement team's interpretation of the data. But guess what? That's what CHIA has done for each and every one of your hospitals in the Commonwealth. So again, I recognize how valuable and what a public contribution these hospital-specific data reports are, because I've worked with many of you in the field on trying to do this for yourself, as well as people outside of the state of Massachusetts. And hopefully what you can appreciate here is the time savings that you have by having these customized reports. So let's move into some of the insights that these reports offer us. So I hope you're going to pull down your own CHIA data report right now, and just for fun, pull down the data report of your favorite hospital. Maybe a hospital like you, maybe it's a hospital within your region, etc. But the compare and contrast is really what can provide some rich basis for consideration and discussion. So, as with any hospital-wide analysis, of course, many times you're going to find that your hospital's performance doesn't necessarily deviate significantly from what the statewide average is, right? That's kind of a function of math. You're not always going to be very different than the statewide average. So I think one of the great opportunities for usefulness of these reports is look for the ways in which you do differ. So I'll just back up here and say, when I look through my favorite hospitals in Massachusetts, either the ones I work in or the ones I'm coaching, one quick view is, we don't differ that much. Blue line and green line are very similar. Blue line and green line are very similar. And in that way, you might conclude that there aren't a lot of opportunities for improvement or cause for concern. I would make the following 2 points. Number one is, I think it is understood, but they're saying that we all have an opportunity for improvement, and that the statewide average in Massachusetts is still among the 10 states in the country that have the worst rates of readmission. So being close to the statewide average is not necessarily something that you should take great solace in, as, in terms of absolute performance. This is not a benchmark. This is just the average in Massachusetts, which, again, is not an average that we're particularly proud of. And then the other point to make is yes, you can look at the ways in which your report is similar to state averages, but I think the great opportunities are where there's variation. So I'm going to flip through a couple examples of variation here. So here, of course, on the run chart, you can see these. You can see Hospital A and Hospital B are clearly a variation from the statewide average. Again, a couple things to look for on this chart is trend over time, and so Hospital A really should feel pretty good about the history of performance, I think, reported here. Hospital A started lower than the state average, and you know what? They're making even further improvements. So that's a nice trend to see. You started lower, and you're making further improvements over time. Hospital B had a little bit of a tougher go, started higher than the state average, might have made some improvements there over, the 2013 time period, but much like the statewide average that we reported in our December report, has ticked up again in recent quarters. And again, we see that. It seems that many readmission rates across the state are ticking up recently, which again, even though the signal is subtle on the run chart, any increase in a readmission trend line should be cause for concern because we were going down in 2013, 2014, and we have taken an upturn in the most recent data set. So be looking for that in your own data. The next area in which you might find interesting similarities or differences is in the payer, the rates of readmission by payer. And so, of course, here in example hospital A, you see that the Medicare readmission rate is that big box, again, reflecting the volume of readmissions at this hospital, or the preponderance is in Medicare as they are statewide. But you can see that each and every one of your adult non-OB Medicaid patients have a significantly higher average rate of readmission at your hospital. This is an important signal and something that's really worth your attention. The big question here for Hospital A is, are you targeting Medicaid patients? And really, you wouldn't be, you would be data informed if you really looked at all Medicaid readmissions because they are significantly higher both than the statewide average and higher than other hospitals as well. In panel B, you can see that's not the same signal for Hospital B. And I just wanted to really recognize that while, of course, I'm always looking for Medicaid readmission rates and concerned about all payer strategies, you know what? For Hospital B, it's a little bit of a different story, and one might not necessarily have to double down a focus on Medicaid readmissions at Hospital B. So this is where, and yet at the statewide level, Medicaid readmission rates are as high as Medicare readmission rates. So I'm a big fan and proponent of knowing your local numbers to customize your strategy to your local situation. And I wouldn't necessarily just say that because Medicaid readmission rates are as high as Medicare readmission rates statewide, that each and every single one of the 60 hospitals in Massachusetts would necessarily have to have a dedicated Medicaid focus. Again, let your data tell you that story. Readmission by age group is something that, again, many of your hospital-specific reports are going to reflect that you're tracking very closely the statewide trends. But as I switch through the 60 hospitals reports, here again is a surprising signal from example hospital A. What we're seeing here in the first blue bar is among your younger and middle-aged adults, age 16 to 24, age 18 to 64, the readmission rate is the highest. It's the highest in your hospital. So again, as you flip through your charts here, this, the graphic may not necessarily jump out at you, but look for the ways in which the signal is different from the green bar. So I think you can readily see that the blue bar and the green bar, statewide versus your own hospital here, is an unexpected pattern. So look for those unexpected patterns, and those are really food for thought, especially in the case of Hospital A, where the natural question would be, are we only focused on older adults, age over 65? Do we need to expand our strategy to address the transitional care needs of our patients who are under 65? I think the answer for Hospital A is a clear yes. Whereas, again, I don't endorse the same strategy for all hospitals across the Commonwealth, so example Hospital B does not have that same problem. The readmission rate in the first blue bar for Hospital B, 10% readmission rate among their younger and middle-aged adults. Not necessarily a problem to focus on. Great. Next slide. love this graph on days to readmissions. And it really, we're always thinking about that 30-day time period. But in my experience, there's some real benefit in thinking about the days immediately following discharge, and then that kind of more medium term in the weeks following discharge. So what we see here is, again, unless you look closely, you may not pick up the signal, but example hospital A has almost 42% of their readmissions are coming back within a week of discharge. Now that is a very clear and compelling signal for some root cause analysis, some sharp readmission reviews, et cetera. You know, dig in there. If 42% of your readmissions are coming back within a week, then I'd love to see a strategy develop around the immediate transitional care preparation and execution and follow-up, whereas a team that has a more evenly distributed preponderance of readmissions across the month, well, then you may think that we need to focus on those weeks following discharge in contrast. So again, look for the areas in which you diverge significantly from others. Readmission by discharge disposition. I'll first bring your attention back to the green slide, the statewide pattern here, and refresh your memory that although many toolkits around readmissions have focused us on that discharge from hospital to home, the readmission rate among patients discharged to either SNF or home health or acute inpatient rehab is always higher, statewide, that is higher than average. And so we need to make sure that we're thinking about readmission risk among patients discharged into skilled care. And again, that can be somewhat counterintuitive because it's natural to think if a patient is being transitioned into skilled nursing care, they would have follow-up attention and support. And while that's true, it's also a marker that they have ongoing skilled needs, right? And so clinically, they are in fact at higher risk of readmission. But and that's not to explain away the higher readmission rate, but the way I like to use that is to say we need to be worried about the patient going into skilled care at least as much, if not more, than the patient that we're discharging to home. And again, you can use this to kind of ask yourself, have we at our hospital been classically focused on readmission, on improving the discharge from hospital to home, and have we yet focused on these other discharge disposition groups that have a demonstrably high rate of readmission? Again, just to point out the variability here between hospital A and hospital B, hospital A has a signal popped up right readily that says, wait a second, look at our readmissions among patients discharged into home health care. Are we doing enough? Are we supporting those patients enough? Are there quality improvement initiatives that we can undertake in collaboration with our home health care agencies to get that number down? Whereas, you know, if you're example hospital B, you might make a different set of conclusions about where to focus your efforts. As Nick pointed out to us, the diagnoses the charts on the rates and the volume of diagnoses leading to the highest rates and the highest numbers of readmissions provide some very rich, locally relevant information. So I really would love to bring your attention to that part of your report. And what you can see here, this is a cut of the discharge diagnoses leading to the highest numbers of readmissions, and comparing hospital A and hospital B. And you can see at hospital A, alcohol-related discharges, sepsis, there's alcohol again, number 3. So number 1, 2, and 3, if you will, are not, quote, Medicare penalty conditions. And so if you haven't yet looked at that data, and if you will, focused on heart failure and pneumonia, well, then what that would tell you is that you're working on, you know, the 4th and 5th most important volume of readmissions at your hospital, but you're missing number 1, 2, and 3. And again, you can just see the comparison with hospital B, a very different a very different pattern, whereas COPD, heart failure, pneumonia, there's number 1, 2, and 3, and you're probably already focused there. So again, you can use this information to just ask yourself, who are we focused on, and is it data informed? The other great insight here that I have personally seen very helpful to teams is this view into what percentage of your readmissions are going to other hospitals. Quick story, hospital in downtown Baltimore that I was working with was tracking their hospitals, their own hospital readmission rates. And their readmission rates, again, were kind of stable over time, and they were trying to chip away at it, but they didn't really perceive that they had that big of a problem, because we'll just say their readmission rates showed that they were somewhere around, 16%, just like our average. And so they were scratching their heads because the state agencies and the hospital associations kept knocking on their door saying, you've got a real readmission problem. Well, when we were able to see what percentage of readmissions went to other hospitals, 40% of their readmissions went to other hospitals, because they're in downtown inner city Baltimore with 7 other hospitals within a 3-mile radius. And so no wonder they couldn't see the information that other payers and stakeholders saw. So again, very special information here that you wouldn't otherwise have access to. And you can see the difference between a hospital A, where a very small minority of readmissions are going to other hospitals, and hospital B, where about a quarter of readmissions are going to other hospitals. And how do you use that information? Well, the information that Dr. Huntington pointed out, they give you the 3 other hospitals, the top 3 other hospitals that your patients are going to. That's the beginning of a collaborative effort right there. So it's very, very helpful information. So a few last words on using these data reports to review and refresh your own decisions on how to target your readmission reduction efforts. What I encourage you to do is to take a data-informed approach to designing your readmission reduction strategy. What do I mean by that? Well, start by asking yourself, as I asked you at the top of this segment, what is your readmission reduction aim? And this is where we have to kind of shed the feel-good, we want to improve care for everyone all the time, and really get down to the specifics of, are you trying to reduce readmissions for your ACO population? Are you trying to reduce readmissions for your Medicare penalty issue? Are you trying to reduce readmissions for your new Medicaid ACO population? If you've got a focus, then this is the time to say what your focus is. What is your aim? What are you motivated and incentivized to work on? Then ask, well, what are the readmission patterns in that domain? So if it's Medicare, if it's Medicaid, if it's all payer, et cetera, what does your data show? Including what are the groups of patients that have higher than average readmission rates. Using your data, then decide which patients and risk groups should you focus on. Many teams, that might seem logical, but I'll just point out that in my experience, many teams start in the reverse order. They'll say, let's do a diabetes-focused initiative. Let's do a heart failure-focused initiative. They decide on who they're going to focus on without connecting it to the organizational aim and what their data shows them. So again, it's all part of the same thinking, but I encourage you to work through step 1, 2, and 3 in sequential order. Let me give you a quick example. Here's a hospital whose goal was to reduce hospital-wide readmissions. They said, you know what, we're not going to chase our tail on this payer, this risk group, what that study shows. We want to reduce readmissions at our hospital for all of our patients. We want to reduce hospital-wide readmissions. So what they did was they did this analysis, looking at adult non-OB. They looked at their adult non-OB data, just like we're doing here in the report, and they said they realized that that all of their adult Medicaid patients had a much higher than average readmission rate at their hospital. So they chose to focus on all Medicaid adults. They also noticed, in this example, they happen to have this data for their hospital, that all of their Medicare patients who were under age 65, i.e. the dual eligible, that had also very high readmission rates. So you'll notice those first two groups are not about diagnosis, are they? They're about a different marker. They're about a marker that really does convey social and economic and functional status, right? So, and then, again, because they knew their patient population and their data, any patient with a comorbid substance use disorder had a very high rate of readmission, and then any person who had a personal history of high utilization also had a high rate of readmission. And that is how they constructed their target population, and thus their strategies to address those target population readmission rates. Quickly, the hospital had a hospital-wide readmission rate of 13%, but when they ran the readmission rate for this combined target population, any patients that met any of those four criteria, that target population now has a readmission rate of 37%, which is 3 times the average readmission rate of the hospital itself. So again, the team was able to feel confident that if they went after these patients with these issues, that they could really make improvements and drive down the hospital-wide readmission rate because they were focusing on a high-leverage target population. The next step is that based on the data-informed target population that you identify, we need to customize the services that we deliver to meet the needs of those target populations. So again, in what we'll just call Generation 1 of readmission reduction, maybe we learned a lot about good teaching and self-management support, making appointments, self-management for chronic illnesses. All of these things are very important. But if you're like that hospital I just told you about, and you're targeting patients with unmet social needs, with economic stress, with behavioral health and substance use disorders, a personal history of frequent utilization, probably those Generation 1 strategies are not going to be applicable to patients with these particular needs, right? And so one standard transitional care model will not work for all of the patients in your target population. And what you really want to do is design components of your readmission reduction strategies to meet the needs of the patients that that have high rates of readmission at your hospital. So in summary, I would ask you to come away from this webinar, first and foremost, download your CHIA report and look at it. And ask yourself, which patients are you currently focused on? Why are you focused on them? Do your hospital-specific data reveal other high-risk groups that you haven't yet thought about? And do your hospital-specific patterns differ in interesting ways from statewide patterns? And then I hope, coming out of this, you could bring back to your readmission reduction team some thinking around whether or not you feel confident that you have a data-informed strategy to reduce readmission based on your own data. So thank you so much for your commitment to reducing readmissions. It's hard work, but with the benefit of these new reports and updated data, we really hope that this will augment and enhance the success of your efforts to reduce readmissions for high-risk patients. Thanks so much.
Thank you, Amy. Looks like we are near the end of the webinar. We could maybe take one question, and I want to make sure that we can also follow up with some of the answer to the questions.
Any questions, Stephanie?
Yep, we do have a question from Rose in chat, and she had a question around, in regards to the profiles. Are the figures inpatients only, or do they include observation cases?
Dr. Huntington?
Inpatient only.
Readmissions are defined as a discharge from the inpatient setting and a return to the inpatient setting within 30 days.
And that is all the questions that we have in chat at this time.
Great.
Great. Thanks, everyone.
We have a few more minutes. I wanted to go ahead and thank all of our speakers. That was a wonderful presentation. I have a few announcements before we end today's call. When you close out of the webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. But if you don't have the time today or you're sharing your computer with someone else, you will receive an email on Monday with a link to the evaluation as well as a link to the event page on our website. As we mentioned at the beginning of the webinar, the PowerPoint presentation is posted on our website, and within a few business days, we'll be adding a recording and transcript as well. Make sure to register for the next webinar, which is on May 4th. I'll include the register option in the email for Monday. This webinar will cover the QIO's Medicare Fee-for-Service Hospital Report. So be on the lookout for that. And thanks again for this great presentation and to all of you for attending.